medical certification of cause of death, or commonly called the death certificate, is an important tool of obtaining authentic and scientific information regarding causes of mortality. Mortality statistics is essential for better planning, management of program, formulation of policies, and for undertaking control measures in an effective and planned manner. It is much useful to know the impact of health services and to evaluate health indicators like infant mortality, maternal mortality, etc. Any planned activity or program can be successful only if the statistical information is authentic and correct. It is to be noted that with concern that Nagaland state is at the bottom to the fourth position among the states in India as per MCCT report 2020. Perhaps this reflects our indolence or lack of seriousness, which will not bring positive impact in the healthcare delivery services and other programs in the state to meet the target population. Only if we can implement the MCCT scheme successfully, then the state can frame a robust health policy and other programs. Further, as per the data of Cancer Control Program, the cases of cancer is alarmingly increasing in the state. Cancer treatment is expensive, which therefore makes prevention and early detection very important to ease the financial burden of the patient. Therefore, the two programs that we are going to launch today is appropriate and vital, and we are deeply grateful to all the eminent professional doctors who are here today to impart capacity training, building, training, provide technical support, and to strengthen the skills of our state doctors and officials. With these words, I take this privilege and the utmost pleasure to heartily welcome each and every one of you to the most important launching program of medical certification course of death and affordable cancer care project in Nagaland, which is a result of Nagaland corporate social responsibility investment and banking conclave recently held in the state. Let this be the beginning of a new chapter towards progression of state health sector in the state. Thank you and God bless.
Nagaland is very fast. I'll give you just brief history how it started. I visited Nagaland in July and that time I came from Bihar. So in Bihar we were discussing this launch of MCCD program. And in fact, sir, no, Mr. Pratay Amrit, who is the additional chief secretary, I discussed with them that we have to do this program in Bihar. And so he said, yes, go ahead and plan. But as you know, Bihar takes a long time. And then I visited here and I met Director sir and V. Khamu madam, and I proposed that if you see the graph of MCCD, medical certification of cause of death, my state, Bihar, is at the bottom. Just 3.4% deaths are having medical certificate. And just above that, I saw Nagaland name, only 7%. So it struck me that why Nagaland is at as madam said, bottom fourth number. And if you see just across the border in Manipur, they are 100%. So, so I thought it's we need to push little bit, and Nagaland can go at the top. And I proposed this idea to conduct this workshop. And in fact, during last meeting only, quickly we have organized meeting with statistics department, health department, and we came out with the idea to do this workshop. So as Madam Imiti said, that why this MCCD is important. As you know, during this COVID crisis, there was a huge problem, and at the Government of India level and state level also, to whether how many people died of COVID. That was a big issue, sir. In fact, UP is the first state who made it mandatory. In the death certificate, they have added one additional column remark, and they said that every doctor or health facility has to certify that, write down whether this death is from COVID or not. And UP government expanded this to all the disease. So they have made mandatory that in all the death certificate, as a doctor or the whosoever is responsible to issue the death certificate, we have to mention the exact cause of death. Why we have to improve this? So there is a saying that what you can't measure, you can't improve. जिस चीज को आप मेजर नहीं कर सकते उसको इम्प्रूव भी नहीं कर सकते हैं. सो इफ यू हैव टू इम्प्रूव this registration, we have to measure the current status. So this is mandatory mainly because of the four reasons. One is to know the exactly why people are dying, to know the community health, whether people in Nagaland dying because of the cancer or road traffic accident or liver disease or kidney disease or some other maternal and child health issue. Unless until we know the exact percentage, as madam say, we cannot decide, take any policy level decision. Like if you know in your state maximum death is happening because of road traffic accident, then you can take policy level decision that the mandatory helmet, mandatory wearing of the seat belt. Right now, the death of Cyrus Mistry had highlighted the importance of wearing seat belt in the rear seat. So all these decisions you can take only when you have good quality data. Third is also to measure impact of any program. Like if you have implemented this program, like I'll give you another example from Bihar. Bihar implemented this alcohol ban. Bihar is a dry state now. So there was huge discussion what happened, whether road traffic accident increase or decrease. And a few years later, sir, when we did the assessment, there were drastic reduction in road traffic accident.
Our experience at the hospital, when death occurs, if any death occurs at a hospital, what happens? This death form, that is form 4, that is attended by, filled up by the attending, treating doctor. And this form is present in all the wards in the emergency room and it is available. Once this form is filled up, it goes to the medical department, that is the MRD section, and then goes to the record room. Now, when any patient dies, this form 4 is given to the patient party. Now, when the patient party requires this death certificate, they require it for some insurance, for some schemes, for GPF or whatever. They require this. They need a death certificate. Now they have to go to the registrar of birth and death and fill up the form 2. And then only they issue the death certificate to the people. Now what happens in our department in the hospital is that this form 4 is retrieved at the record room and we enter all the data into that format and it is entered into the mortality software. So when you want, after it is entered in the software, you can generate this form 4 and also form 2. So what happens is that this form 4 and form 2 can directly be given to the patient also, and they can directly go to the registrar of birth and death to issue the death certificate. So this is the mapping system. Now, where are our sources? Mainly identifying sources where we get our ICU, NICU, wards, emergency room, operation theatre, medical record department, and Registrar of Birth and Death. B. Bora Cancer Institute, Guwahati in 2018. So all the staff got the training there, and after the training was done, we had a meeting with the managing director of the hospital, medical superintendent, doctors, nurses, and staff of the medical record department on the importance of the NCCD and how to go about. And not only that, we even went to Dimapur Civil Hospital and gave training to the staff at District Hospital, Dimapur. Now, how this system is monitored is the managing director, principal investigator, the co-principal investigator, and project technical officer and technical data entry operator. These are the main person who monitors his work. Now, there are some challenges in implementing this program. One is that there is no mortality board. So this was one problem. Another, we had a lot of problem with this. Then second one was that records were not in electronic form. So manually we had to collect data. That certificate is not again mandatory for disposal of that body. So then nobody was doing this work. So Form 2, only very few cases we could complete. Because Form 2, usually when they want to get some scheme, then that's only it was getting completed. Now, another very challenging factor was incomplete details of cost of that. We were getting only the immediate cost of that. Now, we don't know the antecedent and other significant. Oh, I'm sorry. Tuberculosis. Then comes hypertensive disease. Okay, and then your respiratory cardiovascular disease and others. So this is how
the recording of births, deaths, it gives us legal existence for a person. But not only that, these data, the recording, the data on births and deaths, these are important data inputs for policy formulation, for planners, for professionals. Therefore, the importance of having precise, authentic data is there, and we are all aware of that. In India, registration of births and deaths is mandated under the 1969 Registration of Births and Deaths Act, and in the states, the respective states have come up with their own rules, births and deaths rules. In Nagaland, the registration of births and deaths rules is in force. And at the national level, the ORGI, Registrar General of India, under the Ministry of Home Affairs, is the authority for registration, for collection of births and deaths and population registry. In our state, the Economics and Statistics Department has been given the charge for registration of births and deaths. It varies from state to state. In some states, it's the Health and Family Welfare Department which does the registration of births and deaths. In some cases, it's the Municipal Affairs. And in other states, too, Economic Statistics Department. In some states, too, Economics and Statistics Departments take care of births and deaths. In our state, we have a Chief Registrar of Births and Deaths at the state level. Then in the districts, we have the District Chief Registrar of Births and Deaths, where the Deputy Commissioner is the Chief Registrar, with members from the Health Department, from the Education Department, so on and so forth. We have about 1,468 registrars in the state. And the registrars in the villages are the school teachers. We also have the 11 district hospitals having registration units for births and deaths. And as Dr. Tina has already shared, they are already doing registration of births and deaths. In some cases, they're very active. In some cases, not very active. We have also designated the nursing in charge in the CHCs, the PHCs, as the registrar of births and deaths. When it comes to registration of births, it's relatively good, better than deaths. About 72,000 registration happening in a year on an average. But when it comes to registration of deaths, then it's still very low. And it's shared by Dr. Kamo. Unless there is a reason, a purpose, people don't come forward for registration of deaths. Now when it comes to deaths, we have to medically certify the cause of death. And this can be done only by the medical practitioners. This cannot be done by others. And as already shared by Dr. Ravikant, the percentage of registration of medical cause of death is still very low, at 7%. And there is a need to improve this cause of death, as the cause of death, as insights into the cause of death will give us reason to introspect why it is happening and will help policymakers to formulate plans so that the delivery of medical services reaches to the people appropriately. I'm grateful to the various organizations, the TMC, the Health and Family Welfare Department, and the various other professionals for coming together to connect the dots. And I'm very sure that with this program, we will be able to carry forward the agenda of improving the MCCD as well as delivery of health services. Thank you.
Health and public health and medical services, as we all know. Recently, the CSR conclave was organized, the first ever CSR conclave in Nagaland. A good number of companies came. Honorable Union Finance Minister was here, as we all know. And a number of companies had committed various projects to be implemented in Nagaland. I am told about 79 projects have been committed in Nagaland, worth about 50 crores. But what is a matter of satisfaction, I would say, is that out of these 79 projects, almost 50 projects are in the health sector. And out of these 50, 17 projects are relatively prominent health projects. And total worth is about 25 crore for these projects which were committed in under the first CSR conclave. I don't say that it is a big amount of money or the number of projects that are coming is very large, but then anything which helps in improving the health systems in Nagaland is always welcome, and that's why we gratefully acknowledge all the contributions and the projects that have been announced by the corporates for Nagaland. We have committed that we want to implement them in the right spirit and so that the benefits of these projects reach the people. In the last 2.5 years, we have been grappling with the COVID pandemic. All of us, our doctors, our nurses, our health workers, our frontline workers, our CSOs, our faith-based organizations, churches, and every well-meaning person, our tribal bodies, they have all contributed in managing the COVID pandemic in Nagaland. The government also, in its own way, has tried to improve the facilities in Nagaland, and the entire government machinery has been involved in managing the pandemic. Certain parameters we have performed better than other states. Certain parameters we might be lagging behind, but there has been no let up in our effort. And one good thing is that for the long run, a lot of improvement has come about in the health facilities. As we all know, our wellness centers, primary health centers, hospitals, they have all been improved with better facilities. Our reporting systems have improved. In fact, Nagaland COVID tracking system and reporting system was considered to be one of the best in the country. We have had new health blocks added to our hospitals. A large number of doctors and health workers have been recruited by creating additional posts. So all these facilities, they are put in place for the benefit of the people, and we are very happy that this will go a long way in improving our health systems. The other two major projects that are under implementation, I think everybody knows. Nagaland has got two medical colleges. One of them is in Kohima and the other is in Mon. The Kohima Medical College is getting ready very fast, and by I think 75% of the work is now complete. And next year we are hoping to start the academic session. So all the necessary preparations are underway. Medical College Mon may take 1 or 2 more years, but eventually it will also come. Then the other major intervention that the state government is planning to make is the Chief Minister's Health Insurance Project, as we all know. This scheme will basically take care of the in-hospital expenses of insured persons, and it will aim at universal coverage of all the population of the state. So when we talk of affordable health care or affordable cancer care as the topic for today, we know that in our country, since we do not have an insurance-based system, people have to spend money from their pockets. And if you are hit by a major disease, then sometimes even well-to-do people, well-to-do families, they are pushed to poverty. They have to sell their assets and then they become poor. So that is the problem we have been having. Various insurance-based schemes are being launched, and slowly we are moving towards a universal insurance-based system. Hopefully Nagaland will be one of the early states which will actually have this universal healthcare system.
Nagaland TV, Sob Manulaga Awas. Watch us live on Geo TV and on your television sets as well. For Dimapur viewers, we are on channel number 994 in Global Chapter, and Kohima and Mokokchung viewers, switch to channel number 138 on Hornbill Digital. For all news and updates, follow us on Facebook, Instagram, YouTube, and Twitter.